Good evening. Good evening, everybody. This is the third component to the first module of 2025 in the AONA series. This first module is focused on the hip and specifically surgical hip dislocations. We did a webinar last month, followed by a journal club, and this third component, which is a fireside chat. And really what that means is we're going to do case presentations um, and go over thoughts and interrupt each other and share different perspectives about cases that have been utilized or operated through a surgical hip dislocation. My name is Joel Williams. I work in Chicago, and I am accompanied tonight by Doctors Keith Mayo from Seattle, Mike Stover, also from Chicago, and James Learned, who works at UC Irvine in California. These are disclosures. I don't think any of them are relevant or will impact the content we're going to go over tonight. If you're interested in getting CME credits, keep an eye on your email. Within 24 hours, you should be getting an email with a link to claim CME credits. AONA is an independent nonprofit surgical subspecialty society. We're not going to endorse or promote any products or commercial entities. And if there's equipment shown, it's just to illustrate a concept rather than promotion of a specific item. This is an overview slide from the webinar discussing the surgical hip dislocation focus and what we're going to talk about tonight. The fireside really, again, is case-based. Please send in questions. A lot of this stuff is confusing, and if you have a question, I guarantee other people in the audience have the question as well. We're going to talk about indications, technical aspects, and specific cases that we utilize surgical hip dislocations. I'm going to stop blabbing and turn the mic over to James Learned. Then we're going to get through ideally 5 cases. In the webinar, Dr. Stover nicely outlined some of the indications for modern surgical hip dislocation, including trauma, hip preservation, some limited tumor applications, and arthroplasty. That was followed by Dr. Mayo, who went over an excellent talk on some of the technical considerations for surgical hip dislocation. There is a webinar coming up in March, and then we're going to jump right into the second module for 2025, which is focused on distal radius fractures. Similar format with a webinar, journal club, and fireside. Don't forget about 1AO. It's coming up pretty quickly. It is in Henderson, Nevada at the end of April. So thank you. I'm going to stop sharing my screen and hand it over to Dr. Learned.
Great. Thank you so much. Get my... Okay. So here's a case of Pipkin 4, so a concomitant acetabular fracture with a femoral head fracture. And I need to go to the beginning because that would help. Give me one moment. Guess if I...
You're
this
there.
is my first time on Zoom, so you know.
It looks good to us.
Okay. Let's see if this works better. All right. So case presentation. So this is a 19-year-old male who's in a motor vehicle collision. He actually was ambulatory at the scene. He had a little hip pain, but he didn't even present to a hospital. A couple days later, he was using crutches around the house, and his mom was giving him a hard time that he needed to go to the hospital. So he went to the nearest hospital. They got some imaging and called us for help because this is the imaging that they got. So typical non-trauma center that they're going to get not necessarily going to get the views that we are all going to get by default. So they got this image, which is kind of a low AP pelvis. And on this one, I think a couple of important features. One is you can see this sort of fragment here sticking out below the hip joint with an obvious defect in the femoral head. And then hopefully if you're paying attention, you can see that the posterior rim of the acetabulum really is out here and that it's got this big shark bite out of it. We're missing a lot here. And so there's this fragment here that's displaced. So not a normal x-ray. Probably most people would then say, oh, well, let's look at the Judet views. Of course, they didn't get those. They got a different view of the hip. And so we've got this view, which showed a proximal femur, which again shows that femoral head fracture. It looks infrafoveal, looks low. So we did get a CT scan, so I've recreated an iliac oblique here, which shows that the head's reasonably concentric within the socket, but we're not going to see much of a posterior wall fracture on an iliac oblique. We're going to see that on the obturator oblique. And in this view, we can see that you've got this posterior rim, this fragment that's way out back, displaced from where his dislocation was, or his subluxation, which sort of serendipitously reduced. And you notice that it's actually relatively small. When we look at the kind of fractures that you'll see with a simple posterior wall or isolated posterior wall, usually takes off a bigger piece and sometimes multiple fragments. But if you make the head less stable by losing a fragment of the head, then it takes a little bit less of the posterior wall needed to be unstable in order to create a very unstable joint. So the axial looks like this. So we're coming in above the acetabulum here. You can see that the cranial rim right at the dome is really intact. We're starting to see that fragment out behind, and a couple of other small fragments. And it's thin, maybe a centimeter, 15 millimeters wide, but it's really not much. There's not a lot of cancellous bone on that fragment. Probably a large chunk of labrum, we can assume. And then if you look in the fovea capitis here, you can see that there's some fragments. They're sitting in an okay spot there, but then as we drag this along and go a little bit more inferior, you can see that large femoral head fragment sitting there below the transverse acetabular ligament, which is not likely to be in a great spot there. And then on this sagittal reconstruction, again, you can see that the dome's relatively intact. There's that posterior wall fragment that's displaced posteriorly, a little bit of comminution. And then as we work centrally, you can start to see the inferior displacement of the head fragment sitting there underneath the transverse acetabular ligament. Here's a coronal reconstruction. Again, dome intact, head sitting concentrically there, large inferior head fragment. That if it were to unite in that position would obviously cause some problems. You can see the donor site, infrafoveal, and then as we work posteriorly, seeing that posterior wall fragment. And none of my residents would be happy unless we showed the 3Ds. So here's a volume rendered 3D reconstruction. You can see the inferior head fragment sitting there inferiorly. And then as we swoop around posteriorly, you can see that large circumferential fragment that's large, cranial to caudal, but not very wide, medial to lateral. So we have to think about how we're going to get stability there. If you're going to get interfragmentary screws, or you're going to use sutures, use some sort of an augmented plate. So in this case, I think you got a couple of options, right? One popular option for Pipkin 4, where you have a femoral head fracture and a posterior wall fracture, is to treat them separately. Some people would do an anterior dislocation through a Smith-Peterson. That gives you the anterior aspect of the head. In this case, it's a little more inferior, so that might be a little more challenging. And then they would do a subsequent prone or even lateral posterior exposure through usually a Coker-Langenbeck. The other option in my mind is to do this concomitantly, right? To do it at the same time using trochanteric osteotomy and a surgical hip dislocation through that gluteus minimus piriformis interval that we develop. And in my mind, this fragment's relatively posterior, the wall fragment. So this one, I think you really could use either surgical approach, because you don't need to get really far anterior. If it's a little more cranial, I would probably want to use the Gibson interval. If it's a little more posterior, I'm probably leaning more on the Coker-Langenbeck, but probably with appropriate exposure can get to either or. So this was actually a case that came in with my partner, and he called me to help him out because it's not something that he had been doing a lot of, and I had done a fair amount of these working with Dr. Mayo, so I felt pretty comfortable. So here on the left, you can see this AP radiograph of the hip, and you can see that white line in the trochanter where we made our step cut osteotomy. And that allowed us to develop the soft tissue interval so we could dislocate it. And here you can see that we've elevated the head. You can see that the inferior fragment is probably still attached to some foveal ligament, and that's why it's displacing like this. And that's one of the things to consider, that a lot of times that fragment is still attached to its soft tissue. It's part of the reason that it's left behind. And that may be challenging to reduce if you don't release that. Make sure you're able to look inside the socket. So after we were able to visualize that, you can see these inferior to superior screws placed hopefully in an area that will allow for motion, and you can see that they're not placed really deep in the socket. They're placed relatively laterally within that fragment, trying to avoid them becoming prominent if you did develop some AVN or some subsidence. And then we've got a typical posterior rim plate, although what you can see, it's a titanium plate, so it's a little tough to project, but we did fabricate a little spring plate in order to grasp onto that smaller peripheral wall fragment. So we've got a spring plate running sort of radially from the acetabulum, then a typical buttress plate, which is being secured. You can see the depth gauge there in the upper holes. And then here's our final fixation of the fracture. You can see on the left that the trochanteric fragment is still unreduced, so it's still out of position. We're visualizing. You can see the Hohmann retractor elevating that supraacetabular region so we can see our fixation. Make sure that all of our screws are extra articular, and then reducing and stabilizing the trochanter fragment. And that's just two 3.5 millimeter cortical screws placed in lag technique. Really basic fixation. And here's what he looked like in the PACU. So really happy with the overall reduction that we got. Concentric joint, good compression, buttress fixation. Here's his Judet views that we got, so we can show that all of our screws are safe and extra articular. We tend to get x-rays at 6 weeks, make sure everything's healing. At this point, you can't even identify the osteotomy bed in the trochanter, so it just shows how fast the greater trochanter can heal. And then 3 months, pretty happy at this point. He's seeing us regularly, which is nice in this first year. Still talking about things that we are aware of long-term complications that can be avascular necrosis, heterotopic bone formation, especially with this dissection and the trauma to this region, and then obviously post-traumatic arthritis. So it's something we like to get longer-term follow-up. These are 6-month films, again showing reasonably nice union, alignment. And then the last we got was a year out. This is his AP pelvis at a year. So he's united, nothing's migrated, nothing's displaced, and these are his Judet views. So it really allowed us to do one operation to get that large inferior head fragment that we could reduce anatomically, visualize the chondral surface of the head, and then reduce it within the socket, fix the posterior rim. We did, you can see mini fragment screws in that small wall fragment, as well as a spring plate, followed by a supplemental buttress plate in the typical position. Great. Let's see.
James, that was great. You mentioned at the beginning an alternative strategy could be two different approaches, an anterior and then potentially a posterior approach. How do you make that decision, or is this your workflow for Pipkin 4s typically?
Yeah, it's a good question. I think my personal experience leans much more towards a surgical hip dislocation. I think it's elegant to do it through one exposure. It's already a large traumatized region posteriorly because of the fracture dislocation. So I think using the posterior approach there makes sense. If you don't need to add a second exposure and a second capsulotomy, I think that also makes a lot of intuitive sense. I've seen some great results from people doing it through a two approach. So I think it's not one where I think people should try a new technique when they are really good at something else. But I think it's having the ability to do both gives you the option, so that if they have typically these wall fractures, excuse me, the head fractures are anterior. So if for some reason you don't think it's safe to do a surgical dislocation because of the existing injury to the femur or to the acetabulum, then you may want to be able to do that. But in my mind, I typically would do a single approach if I think I can get to everything safely by default.
The only question that came in for that case, James, was why titanium for your spring plate?
Yeah, not for any reason other than it's the sets we had available that day. I don't think there's a reason to use titanium over stainless steel, or in my mind, a reason to use stainless over titanium. A lot of companies have prefabricated spring plates, so you can get them sterile wrapped. You can get them in the set, or you can fabricate your own out of a 1/3 tubular plate, or that's a mini fragment plate that we make into a little claw.
You got that? Okay, so we'll go hopefully through two cases relatively in a straightforward manner. First is a posterior wall, and the next is a transverse posterior wall. This is a 42-year-old that was skiing and had a collision on a cat track in BC and was hospitalized and then was driven by a car 5 days post-op into outpatient clinic for follow-up. It's nothing particularly unusual about this other than the fact that it's an extensive, or I would say probably better termed an extended rather than extensive posterior wall. And the difference being the extensive terminology was used for the ones that involve the entire retroacetabular surface. So we can see some inferior comminution. We can see the entire defect going up the back of the wall. And then on the obturator oblique, you can see the exit distal to the subcondyloid groove and extension well above the joint surface, which is easier to see. I guess I'm going to have to go back to this. On the coronals, which show this sequence of images showing a small area of marginal impaction or comminution and clear involvement of the weight-bearing surface. And so that then brings up the whole question of how do we get where we need to be? There's no obvious debris in this. There is some mild marginal impaction and comminution, but what do we need as far as exposure? These are the axial showing the extension, again, well above the weight-bearing roof, and the same morphology of the posterior wall that we saw in the coronals. So the real question is, how do we get cranial, and what are we worried about? And so on the left, you can see what we should be worried about first, and that is the superior gluteal neurovascular bundle. And then again, this muscle that nobody really understands very well, which is a minimus and is sort of the root of all evil as far as ectopic bone and problems as far as supra and anterior exposure. And the reason why, I mean, why would we need to be anterior? Well, on the left, you have the exposure that is typically thought of as being from a Coker-Langenbeck. And on the right, you have this anterior extension, which is imaginary if you were to do a trochanteric osteotomy. You can see many different variations of what this increase in exposure consists of. But it's always important to remember that you're pushing the limits of this very important structure as you go cranial, less so going anterior. And so how do you get the additional access? Well, if you have a normal proximal femur, meaning not varus and not a short neck, then you can abduct the leg, which helps a lot. If you have a short neck, you can actually make your life more miserable. And internal rotation helps, but remember, you're then tugging on the capsule, which may be attached to your posterior wall fragments. You can do a trochanteric osteotomy, either mono or digastric. Early on, there were a lot of people talking about routine monogastric osteotomies, and that sort of fell by the wayside. And then in addition to that, you can not do an osteotomy. You can mobilize the minimus off the superior capsule and then do a posterior medius tenotomy. And this is the way I was taught. If we needed additional exposure, my initial training would let you know. Okay, why do we want to dislocate? Well, we need to be able to get the crap out of the joint. Sometimes those articular fragments, sometimes they're just discarded. And then in some cases, it'll help us assess the reduction and maybe even help us assess implant position, although we should be able to manage that with image use. So this is what it looked like for him. It was a trans-trochanteric non-dislocated approach. So we basically everted the posterior wall, managed the area of marginal impaction, and then when we went to the anterior extent, this was a reduction based on this screw holding it inferiorly, and these two small 1/3 tubular plates acting as prosthetic cortices. So these complex contours where you're going almost to the anterior spine and into the ischial tuberosity, I think are difficult to manage. And so I would typically try to get the reduction I want and then be able to manipulate the plate multiple times if necessary with this preliminary reduction held in place. So I was prepared to go ahead with a surgical dislocation, but in this case, I didn't need to. I think it's important to try to not do your first trochanteric osteotomy on a complex case. I think it had probably been 15 years since I'd done a trochanteric osteotomy at the point I had done this one. And so I think it was a good place to start. Next case is a 50-year-old male that was hit by a bike on his cycle. He had a closed distal femur on the other side. He's an elite cyclist. I mean, and you have to believe this because he's 50-year-old and cycling can still be extremely competitive. And his imaging showed this image. It's a transtectal transverse. So it goes right through the mid portion of the weight-bearing surface with an extensive posterior superior wall. And the orientation of the transverse is relatively important, and that is it's somewhat sagittally oriented as opposed to being horizontal. And that comes into play when we talk about how we're going to get the reductions intraoperatively. This is the axial cut that tells the story. Again, the transverse component through the primary weight-bearing surface, extending here, and then a large and somewhat comminuted but intact posterior wall. So this goes back to how we were taught individually. When I was in training with Lieutenant, all transtectal transverse variants in young patients were a default option to an extended approach. And that was because they were felt to be they needed to be chondrocyte to chondrocyte, because if they were not, they failed very early, frequently within 2 years. And so that led everybody into thinking, well, what can we do as an option? And so a lot of people were initially then drawn toward the prone Coker-Langenbeck, which is probably best managed on a fracture table. And then occasionally a sequential approach, ilioinguinal Coker-Langenbeck. And then based on Klaus Sigenrock's original report, a Coker-Langenbeck with a surgical hip dislocation. So those were the options. This was a period of time when I would have preferred to do an extended approach, but I thought we could try it with a surgical hip dislocation. And this is sort of the diagram is always shown, and it looks great. Your visualization of the joint is superb. Then you have to imagine how you're going to be able to position clamps from this area to the ischiopubic segment down here. And that's why the orientation of the transverse becomes very important. So the more sagittally oriented it is in this plane, the easier it is to place a point of reduction clamp or a vapor clamp for your primary stabilization. Remember, in this position, the head blocks where you put a shank screw or virtually all of your posterior clamps. You might still be able to put a vapor clamp on the retroacetabular surface and keep the head in place, but it gives you a great assessment, but you're limited in terms of your reduction possibilities. And this is the result we had, and I would like to think that it had taken me less time than an extended approach, but it clearly did not. This is after, I think, 6 different reduction dislocation cycles. And ultimately, the reduction was done with the head in place, and then the reassessments were done with the head dislocated. And I did 3 of these in the transverse family before I abandoned the effort as far as providing any additional armamentarium to what I could do through a prone Coker-Langenbeck on a fracture table, or in some cases, a sequential approach. So here are the the Judet views. They're showing it's the same implant placement that you would have through either an extended approach or a Coker-Langenbeck. And this is, I think, the 5-year follow-up.
Keith, when you talk about the sequence of reduction and clamp placement, so you had the head reduced, clamps replaced, and then were you provisionally stabilizing it with wires, or did you place a plate and screws before you redislocated it to assess the reduction?
No, I think, I mean, it becomes a traffic problem, right? So you have to anticipate where the head, first you dislocate first to see where the head's going to sit in that particular case. And then that'll give you some idea of where you can put clamps on the retroacetabular surface and not interfere. And it's a very small area. It usually is a Weber clamp with 2 screw holes. And then the other more direct access is from the anterior supraacetabular surface to the pubic root. So you're bridging to the ischiopubic segment. It sounds vastly easier than it is. And I think it's partly because our instruments were designed for different approaches.
Mike or James, do you have experience in treating acetabular fractures aside from posterior walls through this approach?
Yes. So I've done it the same as Keith. So I've done it for patients with large posterior wall fractures with a associated transverse component. So the one thing you can do if it's a larger posterior wall too is with the head dislocated and a clamp anteriorly, you can place a bone hook onto the ischiopubic segment through the wall fragment to help hike that up posteriorly with the head dislocated still. But I agree with Keith. I think there probably needs to be some look as to what we can do as far as different clamps for the approach.
One question came in, Keith, during that last presentation, which is, how do you typically repair the labrum in these posterior wall fractures?
Well, the majority of them still have a superior labral hinge. And if you have to dislocate, then you have to decide what you're going to do. So I think the principles say that you preserve the capsular attachment to the posterior wall, and then that makes you decide where you're going to section the labrum. So you usually have to cut the labrum with a 15 blade at the anterior cranial limit of the posterior wall and incorporate that into the capsulotomy. And then you put the wall back, and over the years, I've actually, most of the time, I haven't done anything to that little tag that sort of hangs off the inferior part of the posterior wall where the labrum's been avulsed off the rim. I mean, I have a few times put it back with a suture anchor, but if you're freeing up the anterior hinge of the posterior wall in situations in which that's the pattern, you don't have to do anything, at least in my view, mainly because I don't know how I would repair it. I've cut it perpendicular to the labrum at the anterior limit. And when the head goes back anatomically, those surfaces are realigned. So maybe it's since I don't have a technique for doing it, I just haven't done it.
Okay, thank you again. Keith, this next case is a 24-year-old gentleman. He was drunk driving in a car crash. He showed up with this AP pelvis X-ray. Hemodynamically stable and neurovascularly intact. This is his 3D CT scan, which is nauseating that he went to the CT scanner before his hips were reduced, but it was there when I was putting this case together and thought it would be a illustrative component to his presentation. So right after the CT scan, they called us. Closed reductions were performed in the emergency room. The right side was managed the next day by my partner. The pattern was a transverse plus posterior wall, treated through a prone Coker. And this is the situation and really the focus of this case on the left side. So he had an obturator dislocation. It was reduced shortly after he arrived, but he has this large defect in his femoral head. His right side was managed postoperatively with restricted weight bearing for 2 or 3 months. I forget exactly how long. And the left side with the femoral head lesion he was permitted to put weight on it for transferring, but really that was about it. So after 2 to 3 months, his weight bearing was advanced on both sides. So he was heavily wheelchair dependent initially. And he sort of had vague mechanical symptoms on his left hip with just normal physiologic activity. He really wasn't an athlete or trying to get back to sports or anything, just with normal walking. He described clicking and pain with walking even short distances. So at this point, he's about 6 months out from injury. His defect dimensions are listed at the top of the screen as 30 by 5 approximately. And for an older patient, I think it would make sense to let the symptoms play out, and if and when an arthroplasty is warranted, then that should likely be the plan. For a younger patient, I think still keeping in mind the limitations or durability averages for hip arthroplasty, I think preservation options warrant some consideration. This is his MRI, which is about 6 months after the injury. The edema that was present within his head neck junction around the lesion it was resolving somewhat. It definitely wasn't completely gone. You can see on the sagittal view over on the right, there's still some edema in the vicinity of the lesion. But the initial MRI had much more edema tracking down the neck and into the intertrochanteric region. At this point, I really counseled the patient or talked about options and said we can let this be and see how it plays out. And if and when the entire joint develops an issue, we can talk about arthroplasty and talked about the pros and cons of that versus a preservation technique where a fresh size matched allograft plug could be inserted into his defect. This is a technique that I think is probably best described for the hip at least as experimental. I think there are more publications and more data to guide the conversation for osteochondral defects or osteochondral allograft treatments for the knee. But there's really not a whole lot of data on the hip. There are two companies which offer fresh allografts. I don't have enough information to say which one is better. So essentially, when I have a patient like this that's a candidate that wants to pursue it, I request a graft from each company, and whoever procures one first is the one that drives the plan forward. This was also preceded by a diagnostic arthroscopy, and something I've learned from Brett Christ about this specific technique is that if there are any acetabular cartilage changes during either on an MRI or on a subsequent arthroscopy, we shouldn't be offering this technique. So this is a femoral head specific technique, not a bipolar or a acetabular lunate facet technique in addition to femoral head technique. So if there are any acetabular changes, probably best to abort this idea. His cartilage looked good. He did have a labral tear, which I did not address during the arthroscopy. It was saved for part of the plan during the dislocation. This is an intraoperative photo. I utilized a Gibson interval step cut osteotomy like was discussed during the webinar. There are different sizes, and I don't have time in this presentation to get through all the instrumentation techniques of an OCA plug, but essentially you have to measure the diameter and depth. And it is advisable, I think, to soak the plug once it is harvested from the cadaveric femoral head in bone marrow aspirate, which has been concentrated. Most of his labrum was repairable. There was a small portion which I did augment with some of his own tissue. That's the same intraoperative photo at the top left, but this is a picture of the back table in preparing the graft from the cadaveric specimen. These are his x-rays right after surgery. And unfortunately, this is the last time point that I have on this particular individual. It's 8 months post-operative. At this point, he's walking around pain-free. He did do some physical therapy initially. And I think this is the last clinical image I have of the guy. So take-home messages. This is one of the many ways, one of the many different techniques that can be utilized using a surgical hip dislocation. We've heard about some of the other traumatic indications. This preservation, I guess, sort of the intersection of trauma and preservation. This is an uncommon situation, but I think it warrants some consideration in patients that are younger and are not ideal arthroplasty candidates. I think it's important to plan all cases, but cases like this, which are a bit more nuanced and technical, and it can be very useful to practice something like this on a cadaver and talk to people that have experience to guide you through the decision making and conversations and some of the technical nuances.
Joel, I think it's a very interesting and powerful use of the graft. But what we're waiting on is just long-term follow-up, how the grafts perform long-term. I've had some experience, and I know that Brett Chris has plenty of experience with the allografts too. And I've had patients that seem to do pretty well for about 6 or 7, 8 years, and then they tend to collapse. It's not that the graft collapses, but I think the cartilage overlying it tends to wear out. But I think it's a good technique.
You think the cartilage on the plug itself thins down and
Yeah,
disintegrates?
I think it wears away. At least I've had a couple that have worn away, and then we've gotten MRIs of those patients too, and I think sometimes maybe the graft doesn't incorporate very well. Maybe that has to do with the health of the cartilage overlying it. But I think for individuals like this guy, I mean, you really don't have any other options if you're going for a preservation. So I think it's definitely worth a effort to give him a hip that if it lasts 7 or 8 years and does pretty well, I think that's worthwhile.
Keith or James, do you have any experience or thoughts about the OCA technique?
I've done one. Like yours, it's sort of it's a bit, I don't know if I want to use the term Hail Mary, but we're just trying to preserve this hip because of young age. And it was a similar thing. We ended up with a sort of dual graft, kind of a snowman graft, because I was a little oblong and we didn't want to go to a large diameter. And the procedure is very technically challenging. I think your x-rays show an excellent result, and the long-term follow-up is my exact experience is your guys, which is looks great, and then you just it's a bit of a ticking time bomb. You know it's going to have some complication, or at least we all believe it's going to. And so I think just a good conversation with the patient ahead of time and giving them an understanding that this is going to do, it's going to require long-term follow-up and that you're going to have a long-term relationship.
I think the unclear thing is, I mean, the laboratory study suggests that chondrocyte viability has been improved for longer durations of use of the allografts. Whether that translates into a better long-term survival, as Mike has pointed out, is questionable. It probably still is preferable to oats, which, I mean, I did probably a dozen oats procedures in the femoral head early on. So the mosaic plasties have the advantage of being autografts, and a lot of these heads are big enough that you can take multiple plugs from the periphery But then you have to remember that the periphery of the femoral head, the cartilage isn't as thick. And so you actually have even though the cartilage looks smooth when you're done, if you have templates that show you that you're congruent, the subchondral bone is at different levels. And I think it puts the cartilage in a different stress level. So that was an initial idea, but I think that the allograft looks better just because it gives you a concentricity which is improved over any kind of mosaic plasty.
One question is talking about, is it necessary to do the trochanteric osteotomy to get the hip dislocated? My experience is yes. You can recreate the traumatic dislocation without a trochanteric osteotomy, but that's not really what we want because it won't give you the visualization. The power of the dislocation in my mind is separating the abductors from the rest of the proximal femur. That's what gives you the visualization and the access. So I don't think that using a traumatic interval to dislocate it is going to, number one, give you the visualization of the typical fracture bed. And two, it's not going to give you the visualization of the anterior superior acetabulum where we're often needing to be. Other question about new technology, 3D printing, custom prostheses. Yeah, we'd love to see applications of it. But we don't have any sort of implants to this point that are proven for any sort of longevity. I think we're looking more to avoid metal implants in these settings. But yeah, I think three-dimensional templating is great. Can give you a lot of assistance in orienting yourself, but it's hard on a spherical object because there's not a lot of reference points.
I think, can I just say, one thing, the original Siebenrock paper was only 12 patients, but 8 of those were anterior dislocations and 4 were posterior dislocations. So, and I think there were only 2 posterior wall, posterior columns. So you have to decide why you're dislocating. If the reason to dislocate is the usual one, which is to get junk out of the joint or articular fragments, which you're going to use in the reconstruction, and you have a big enough posterior corridor through the wall, then a posterior dislocation is okay for that. But I mean, as far as the anterior dislocation without a trochanteric osteotomy, I'm not sure it's possible physically to do it. I mean, we've obviously all seen dislocations that are traumatic, but even going through a case, and Mike, I'm sure you've seen this, where you've done it. You've got a capsulotomy, you're all ready to dislocate in a young male, and the ligamentum teres is what's keeping you from dislocating. And it can be an extremely difficult dislocation in that setting. And so you just have to decide why you're dislocating. In some cases, a posterior dislocation will be adequate, but you should be prepared to go either way.
I would agree with that.
You ready, Mike?
I guess. Here we go. Is that it?
Looks
Did you
good.
look? Yep, it's slideshow good.
Okay, so this is a 23-year-old baseball player. He was stretching to get to first base. And on his left leg, he had his body flexed over it as he hit the bag, and then he had immediate pain, inability to walk. So here's his immediate injury x-ray. So you can see here that on his normal hip on the right, you can see he's got this very low volume socket, acetabular retroversion. So you can see his crossover sign here. And then he also has quite a bit of lateralization of his femoral head in his normal socket. And on his injured side here, you can see that the joint itself looks a little bit narrowed, or you could imagine this is maybe sublux, but also narrowed, both things at the same time. because the head is not that much farther lateral. So this might be a little bit of a pre-arthritic hip. So he had pain, and here's his CT scan. So he presented to our clinic with the CT. You can see here he's got a large cam morphology on the anterior aspect of his femoral head neck junction. Maybe a little bit of posterior head tilt and this very small posterior wall fracture fragment, and a relatively retroverted socket. So if you look at his CT axial cuts, this is at the 1 o'clock position on your left. You can see the acetabular retroversion in the cranial aspect of the joint. And even down here at 3 o'clock in the center of the head, you have a neutral position of the walls, which should be probably a little bit more towards 15 or 20 degrees of aneurysm in that area. Here's his MRI. You can see that he has some cartilage damage here along the anterior medial aspect of the femoral head. And you can see that this may or may not be a subluxed hip. I think it's hard to tell on the MRI. So my plan was, I'll go back to here, my plan was actually to perform probably a surgical dislocation in order to address all the things. He's probably got what I call a mixed morphology hip. He's got a very low volume socket. He's got a cam morphology of the head, and I believe that this injury occurs when you go into forced hip flexion, and it's probably somewhat of a levering event of the head on the anterior rim, as well as a straight posterior superior directed force. So my thought was to address all the things that were associated with this patient other than his acetabular retroversion or lower volume socket, which I don't think could be addressed probably at the time of the injury. So we did a surgical dislocation. You can see here's a very classic anterior acetabular cartilage delamination along with the associated labral tear. So he's been impinging on that hip for some time. So we initially did the repair of the labrum. You can see right here, 3 suture anchors and incorporating some of the delamination. Oops, sorry. Here's his femoral head. So this is indicative of what we saw in his MRI. So he's got a parafoveal injury to the cartilage. Here's his foveal region, and this is the area adjacent to it. The cranial portion of his head is actually in pretty good condition. You can see over here is his head neck offset. So through the dislocation, we also cleaned up the edges of the cartilage defect. We did a microfracture technique. I didn't think it was worthwhile trying to transplant cartilage at the time of the injury because, as Keith noted, the cartilage on the anterior aspect of the femoral head was actually very thin. We did try to harvest some of it during our osteoplasty, and then you can see where our osteoplasty ended up here at the same time. So then on the way out, we did the fixation of the small posterior rim. You'll note that even at the time of the reduction, that there is definitely a difference between the two acetabular cartilage thickness dimensions between the two. And then you'll see here that there really is not any significant subluxation of the head. So this is a little bit interesting. He's a very muscular individual. So this is his 2-month or 3-month post-op x-ray. You'll see that he's got significant vascularity in the head, and he's almost got a little bit of a disappearing head, which is a little bit anxiety provoking in a high level athlete. You're a little concerned at what's going on there, but I think that just proves that the vascularity is in good condition. So here he is now at 2 years out, returned to playing baseball. Still has a little bit of narrowing of his joint space. It is consistent, and it's actually been the same width the entire time. So I think it was probably part and parcel to his wear patterns that he was experiencing from his mixed morphology hip. And then you can see, I think I have one more film, or it's not coming up. So, nope, I can't find it. Oh, there it is. So here you can see, it's just the measurements blown up. So you can see his joint space narrowing, no lateralization of the head. and he's performing at still a very high level. So just an interesting hip shape, and I think probably the best treatment for it, especially in the setting of some early subluxation of the hip.
Michael, in those cases, in those images, it looks like he's got either a kind of a corresponding, increased femoral anteversion to go along with his retroverted socket. I don't think acutely doing that in isolation, but is this someone that you'd consider a repositioning osteotomy of the acetabulum or the proximal femur, or is this someone at that athletic level that just let them go until they have problems?
Yeah, I don't think he wanted to hear anything about any future reconstructive surgery. I think it was about just getting back to play.
Yeah.
I think that his femoral version is actually, I do have MRI cuts of that, and his femoral version is really only about 14 degrees, so he doesn't have any associated higher femoral anteversion with it.
Question about post-op weight-bearing protocol for a patient like that?
I still give him 6 to 8 weeks of 30-pound weight bearing, no hip range of motion restrictions. I want the hip moving pretty early afterwards, and then progressive weight bearing. I think he was at 2 months. I was probably a little bit cautious, especially when his head started to disappear.
Yeah.
Did you utilize a CPM machine, Mike, for that case, or what are your thoughts on CPM in general?
CPM, I did use it early on.
These are difficult discussions because you know that hip is doomed long term, and yet all anybody want to hear about is the next 4 year or next couple of years of eligibility. I mean, so in a retroverted hip like that, a small volume, you're certainly reluctant to take any of that offending anterior wall, which is part of the impingement. So you're just sort of hoping against hope that it's gonna defeat the projected natural history.
I don't think it will. I mean, I think that we had the discussions when he was healed that, if it was anybody else, I think reorientation would probably
Yeah.
be indicated. But I don't even know if his reorientation would be indicated even at his age, because he already has some cartilage thinning and he's got now a femoral head lesion with it. And I think probably the horse is out of the barn with that hip. So
One additional question came in that says, great presentation, small posterior wall fracture without dislocation. Is it necessary to fix in an obese manual worker?
I think, for me, I think it has a lot to do not just with the size of the wall, but the associated morphologies of the hip too, whether or not they have impingement, why they ended up with that fracture. I mean, but it still comes down, a lot of people will do stress examinations on the patients, and if they're stress negative, then leave them alone. But I think in certain individuals, I think especially people with higher force levels and higher requirements of their hip, I think I'd want every part of the hip there, especially if it was part of a maybe lower volume hip or with an associated larger, cam morphology of the head. I think I've been quite aggressive on those patients.
I think the mechanism plays a role too. I mean, this is Mike's case, not a particularly dramatic mechanism, and it's due to the underlying pathoanatomy. And so the underlying version of the hip and the femur, as well as the issues with whether or not you're going to be able to manage the location. So I think we all have experience with small posterior-superior rim fractures with dislocations and marginal version I mean, I think we've all had a handful of cases where we inherited those with secondary dislocations or instability. So I think the post-row superior walls, even with a normal volume acetabulum, make me very nervous. And I can't point to a study that shows that they're a malignant lesion, but I think that certainly the ones I've seen problems with late instability with an original dislocation have been in that family. And then, of course, I think in all these relatively low velocity injuries, I think they need a full workup, which includes femoral version as well.
Well, thank you, gentlemen. I think we are about out of time. If there's any other questions or comments, go for it. Otherwise, thank you to April and Mackenzie from AONA that helped us organize all of this and helped with the logistics.
One thing I would just add to is just what do people do for heterotopic ossification prophylaxis in the setting of the surgical dislocation?
Funny, the question just came in asking about a role of bisphosphonates for post-dislocation patients.
Yeah, bisphosphonate.
Bisphosphonate.
That was the question. So is there a role for that? I don't think many of us are using bisphosphonates. There was some initial or earlier, like Didronel was used a lot. But the problem is it works as long as you're taking it, preventing the ossification. And then as soon as you stop taking it, it tends to form a bunch of bone. Most of us probably are using some role of either radiation in recurrent patients or either indomethacin or Celebrex.
Yeah,
Yeah, I personally use Celebrex, so and it's been pretty effective. But you can see even on that kid, large muscular kid, he still had grade 1 heterotopic ossification around the trochanter and also along the peripheral rim of the socket.
I think Celebrex, when people go home, typically Toradol in-house. Radiation seldom. It depends on all the other sort of typical risk factors, in addition to the surgical time and tension on the minimus throughout the case.
I think that my personal view, and I know it's a minority, is that there's nothing special about the minimus, and you should use the same debridement criteria for that muscle that you use for all other muscles. So if you're kind to the minimus and it's contractile and bleeding at the end of the case, you don't need to do anything. Now, if there's been a dislocation cavity and you're looking at a giant perimeter of dead muscle, then it's obvious that that's not going to do well. But I don't think that a priori the minimus has to be on block excised.
Thank you all.
Questions?
Thank
Thanks,
us.
audience.